And good morning, good afternoon, good evening to everyone. This is Megan, and I just wanted to welcome you all to our webinar today, which, as Greg duly noted, is summarizing some key work that we've been conducting over the past year. I'm just going to briefly start off this webinar before handing it over to my colleague Sarah to deliver the bulk of the majority of today's content. Throughout the webinar, you're welcome to type your questions into the chat feature where we'll be monitoring your questions, but also we plan to save about 20 minutes at the end to review and discuss some of the Q&A that comes in. So again, just keep typing those in, and we hope to save sufficient time to address those at the end. Today, Sarah will be going over some background and rationale for why this is such a critical and important topic, the findings of our exploration, some key opportunities for action, and of course the Q&A, as I previously mentioned. And just for those who might not know Jhpiego, Jhpiego is an international organization headquartered in Baltimore in the USA with programs in nearly 40 countries around the world. And our mission, as you can see there on the slide, is to create and deliver transformative healthcare solutions that save lives, and doing so in partnership, building provider skills, developing systems, and guaranteeing a healthier future for women and their families. And with that, I'm going to hand it over to Sarah.
Awesome. Thank you, Megan. And thank you, everyone, for joining us today. We are excited to share this research with you. So to kick it off, we want to begin with an imaginative scenario similar to what we might find in a global family planning program. Imagine that country X is receiving significant global donor funding support to procure family planning commodities and to implement and scale up family planning service delivery. During the implementation, several implementing partners and CSOs will work alongside the Ministry of Health and local health facilities. In a moment, I'll be asking a series of questions related to equipment and consumables for family planning service delivery. For these questions, I want to make a distinction between the contraceptive commodities, like IUDs and implants, versus the equipment and consumable supplies needed for service delivery, things like medical gloves, iodine, forceps, or specula. The questions will focus on equipment and consumable supplies needed for service delivery. In the first question, and in your experience, who is typically responsible for procuring the forceps, gloves, and other equipment and consumable supplies needed for family planning service delivery? To answer, please type your questions into the chat box, and if you don't know the answer, please write "I don't know." We'll give you all a minute to respond. All right, I hope that's given people a chance to type in some responses. Greg, would you mind sharing some of those initial answers coming in?
Absolutely. So first one we have is "I don't know." Procurement persons, IPPF, governments would be responsible, Ministry of Health, not UNFPA, Ministry of Health, population and health departments. There's people who are responsible for consumables and procurement. The NGOs themselves that aren't using the MOH supply chain. The organization is responsible for procuring these: MOH, UNFPA, USAID. So that seems to be the list we have so far. More to keep coming in.
Awesome. Thank you, Greg.
You're welcome.
All right. We will move on to the second question. Next, in your experience, who is typically responsible for paying for the equipment and consumable supplies that are needed for family planning service delivery? Again, we'll give you a couple seconds to type those answers in. All right, Greg, would you mind sharing a couple of those answers with us as well?
Sure. We have President, Ministry of Health, Chairman of Health Center Management Committee, IPBF, Ministry of Health and the donor, the Health and Population Departments, Ministry of Health with funds coming through either the Treasury or through external funding to the MOH centrally, or the cost recovery system. Facilities ordering them might need to allocate budget for consumables. The clients, as we are providing a service, so we basically put a service charge. Our organization can pay this in the form of local source to income and subsidy. Donors, NGO, Ministry of Health or Finance, in some cases donors, external development partners and private organizations, again, Ministry of Health, donors.
Awesome. Thank you, Greg. And the final question that we have is, in your experience, who is typically responsible for verifying and monitoring that equipment and consumable supplies are available for family planning service delivery? Again, we'll give you a couple of seconds to type those answers in. All right, and Greg, would you mind sharing a couple of those with us too?
Sure. So the answers we're getting so far are NGO supply chain staff at the facility in charge, MOH, nationally not sure, Ministry of Health again, self-monitoring by Health and Population Departments, and sometimes CSOs and clients do report back. Rarely monitored well, but if done, would be through the LMIS, which is not managed by the Family Planning Unit of MOH. The education or the ED and the administration department of organization that is in charge with purchase, program division and facility staff, executive director of Family Planning Association. So those are the answers we're getting for this question.
Awesome. Thank you so much, Greg. And thank you everybody for your active and thoughtful participation in this activity. The reason that we wanted to kick off the webinar today with this exercise is twofold. First, we wanted to position this conversation in the context of a common scenario, one where several global stakeholders are working alongside one another on family planning service delivery to procure, fund, and monitor the materials needed to make implementation possible. Second, we wanted to see if there is consensus among a global community of stakeholders who work on this issue as to the division of roles and responsibilities when it comes to procuring, funding, and monitoring the equipment and consumable supplies. Even on this call, mostly comprised of supply chain experts, CSOs, and global health experts, there was, at least to some extent, some differing ideas about responsibilities within the family planning community when it comes to these materials. And this particular issue is really what motivated our interest in exploring this topic in the white paper. These questions and the inconsistency within them largely motivated Jhpiego's interest in this topic and in working with RHSC to produce the white paper. Before diving into the key findings from this one-year opportunity, I wanted to provide a bit more background information and context to position those findings. This project was a one-year collaboration with the Reproductive Health Supplies Chain Coalition through the Innovation Fund. The primary goal of the project was to provide a comprehensive analysis and evidence base that explored how the unavailability of equipment and consumable supplies impacts family planning service delivery. And second, we wanted to explore what was driving the unavailability of equipment and consumable supplies. And finally, we wanted to create a sense of urgency for collective action on this issue, including a series of recommendations and advocacy approaches. This project took the form of a white paper, which was published in February 2020 on the RHSC website. In addition to the white paper, we are working closely with RHSC on various dissemination activities to call attention to this issue and the key recommendations to begin to ameliorate it. After consulting with donors and other partners, we opted to submit a proposal to the Innovation Fund to explore this issue. The group determined that a white paper on the topic could help launch our community into action. So our effort to develop a white paper was about assembling fragmented knowledge and perspectives into a shared evidence base and then generating collective urgency for action on this issue. The white paper is now available on the RHSC website at the URL above. It was also included in the webinar invitation that went out to your emails, and we will be sure to post it after the webinar. In the webinar today, we will review the key findings and our recommended opportunities for action. The white paper has more information, specificity, and recommendations. If you are interested in learning more after today, we recommend that you check it out. Before continuing, I want to provide a bit more clarity and context on the type of materials that this paper centered on. For the purposes of the paper and our investigation into this issue, we primarily discuss these items in two major categories: consumables and equipment. Consumables are expendable materials for one-time use, including things like gloves, gauze, anesthetic, and iodine. Equipment includes the instruments and other reusable materials, which are generally used more than once, things like towels, forceps, scalpel handles, and kidney dishes. While items like autoclaves could be considered as equipment, we generally focused more so on items needed at the immediate time of service and less on items needed upstream. The parameters of this paper include focus on reproductive health, and upstream equipment is rarely isolated by service area. Throughout the white paper, as well as in the presentation today, you will hear us mostly referring to LARC methods, like IUDs and implants. This is because as we see a global method mix shift towards LARC methods, the need for increased equipment and consumables also increases, since those methods are more material intensive. That is not to say that methods like condoms, birth controls, or Depo-Provera don't require supply chain considerations or materials, but rather that the shift towards LARC methods globally further heightens the need to address equipment and consumable supply concerns due to the increased materials that these methods require. Second, moving into the rationale for the paper. In the past several years, the family planning community has celebrated significant strides in strengthening the global supply chain and addressing critical barriers for service delivery. These achievements have included progress in reducing commodity stockouts and strengthening the health workforce. Global method mix shifts towards methods with greater consumable and equipment needs, like the LARC methods we mentioned earlier, have exposed longstanding gaps in consumable and equipment availability related to family planning service delivery. This white paper was assembled as a means of compiling the existing knowledge that already exists on this topic and giving stakeholders something to build from. This may not necessarily bring forward any new information per se, but that wasn't the point. The Innovation Fund mechanism doesn't allow research, so we were limited in the types of sources and data that could be included. The purpose of this paper was more to explore how this challenge impacts family planning goals and considerations about what may be driving it. During its implants removal program, Jhpiego had faced persistent and intractable challenges regarding the availability of equipment and consumable supplies. In our efforts to expand access to quality removal, we continued to see barriers across country programs in stocking all of the equipment needed. This reality was clear in our Kenya and Uganda removal work, and unfortunately validated in all 4 additional countries under our current grant. The graph above shows the startling results of our landscape assessments in each of the 6 countries in which we've done our implant removal work. As Jhpiego continued to work on this issue, we were interested to see if this challenge was popping up in other locations and other programs. These findings were also validated by the DHS service provision assessments. While the SPA surveys for family planning were only available in a handful of countries, the findings were very similar to what Jhpiego was seeing in our own programs. These surveys were conducted only in facilities that were already providing IUD and implant insertions and removals. As you can see in the data, about 33 to 90% of the facilities surveyed that provide IUD services had all of the necessary materials for an IUD insertion or removal, did not have all of the materials necessary for insertion or removal. Most commonly, the materials that were out of stock were the tenaculum and the uterine sound. For implant insertions and removals, about 54 to 92% of the facilities surveyed did not have all of the materials needed, though this number includes the implant itself. Most commonly, the material out of stock for implant insertions and removals were the scalpel with blade or the grasping forceps. While the data on this issue are still limited in scope and also in geographic coverage, the DHS data shows a similar trend to what we saw in the Jhpiego program data, that the availability of equipment and consumables for family planning service delivery was creating a barrier to quality service. Before we talk about the key findings, we also want to give you a sense of the methods and processes that we followed to create this paper. In order to begin to collect the fragmented global knowledge and evidence that already existed on the issue, we broke the processes and methods into two major components: consultative methods and desk review activities. In the consultative process, we started by convening a technical advisory committee comprised of supply chain experts who could help shape the direction of the white paper, as well as provide feedback. We also engaged stakeholders at two key RHSC meetings, including the SSWG meeting in October of 2018, where we conducted a root cause analysis and shaped early exploration priorities. We followed that meeting with a presentation in Kathmandu during RHSC's annual meeting in March of 2019, where we were able to shape preliminary findings and seek feedback about next steps and issues to further explore. Finally, we conducted a series of consultative workshops in country, including Uganda, Nepal, and Ghana, in order to convene stakeholders and conduct supply chain mapping exercises, SWOT analyses, and prioritization activities. In each of these sessions, we included stakeholders from CSOs, health facilities, national and subnational government representatives, as well as providers. Uganda, Ghana, and Nepal were selected to explore three very different supply chain and family planning landscapes. The desk review activities included a traditional literature review, supply chain surveys, and review of existing data on this issue. The literature review explored combinations of search terms, including family planning, contraception, consumables, equipment, and availability. This review was later expanded to include RFPs and RFAs for major contraceptive procurement awards in order to see how other gray literature on the topic was addressing the issue of equipment and consumable needs. We also sent a survey to two key supply chain working groups, the International Alliance for Public Health Logisticians and the Reproductive Health Supplies Coalition, in order to seek better understanding of equipment and consumable supplies within contraceptive service delivery from the viewpoint of supply chain experts. And finally, we reviewed existing data, both from performance monitoring for action and the DHS service provision assessments, to see to what extent this challenge had been documented. There were two sets of key findings that we were most interested in exploring in the white paper. The first was how equipment and consumable insecurity hinders the achievement of family planning goals. And the second was what is driving that insecurity and what are the subsequent opportunities to resolve these drivers. So with our first question, how does the unavailability of equipment and consumables for family planning service delivery at the facility level hinder the achievement of family planning goals? In looking at global family planning goals, like 120 million new users, for example, we start by focusing on individual outcomes, things like uptake, need, choice, and experience. These outcomes at the individual level are then tallied up to comprise broader global goals. To understand how this issue of insecurity could impact individual goals, we want to present a framework that includes 4 pathways in which consumable and equipment insecurity at the facility level might be suboptimal to achieving family planning goals surrounding choice, need, and uptake. Through the individual lens, we can better understand how this insecurity hinders family planning goals. Of course, there are several other barriers that could stand in the way of safe, quality service delivery, but this framework highlights the potential scenarios that could stem from the isolated issue of equipment and consumable insecurity. Along the top of this graphic, you see the ideal pathway. The health facility is equipped with the necessary equipment and consumables, and the individual seeking family planning is able to leave with the method of choice, achieving her personal family planning goals and reinforce trust in the health system. When the facility does not have the necessary equipment and consumables, however, there are 4 potential outcomes that we explore. First, the individual is denied or referred. So this means that the service is denied completely, or the individual might be denied or referred to a different health facility to seek care. Second, the individual may be required to purchase the needed supplies. So the health facility might say, you can come back to get the IUD, but we first need you to go to the pharmacy and procure this list of materials. Third, the individual may receive the family planning service anyways, though potentially at a lower quality or a compromised quality. And fourth, the individual may receive a non-preferred method of family planning. So an individual might be seeking a LARC method, but instead leave with condoms or birth control pills. In each of these scenarios, the individual is put at risk by gaps in care, potentially resulting in increased individual financial costs, higher risk of unintended pregnancy, or side effects from a procedure that was not delivered at high quality. In each of these pathways, the outcome is a decline in users or a restriction of family planning goals. These pathways also bring into consideration the issue of equity. One could imagine that for young people, rural or distant populations, or lower income individuals, these outcomes would be exaggerated. For example, if an individual is required to travel a longer distance, absorb the travel costs, and also procure additional materials for the service, she is put at higher financial risk, something that would be exacerbated if she was already living in a low income setting. It is also important to note that in this scenario with compromised access to the method of choice, the healthcare worker is potentially put at risk as well, due to exposure to bloodborne pathogens or other compromises to personal safety due to a delivery of a family planning service without the ideal equipment or consumables. This framework sheds light on the relationship between equipment and consumable insecurity and the achievement of family planning goals, and how this issue impacts the achievement of global family planning goals. The second question that we are interested in exploring is what then is driving equipment and consumable supply insecurity? In order to answer that question, we look at 5 different drivers of equipment and consumable insecurity. So we want to start with a caveat that this list is certainly not exhaustive of all potential drivers of insecurity, nor does it fully cover all actors within the global reproductive health supply chain. These are, however, the primary drivers that we uncovered throughout this process and through our investigation into this issue. First are commodity donors. Donors do not always articulate expectations with governments or grantees, nor do they regularly fund equipment and consumables. Throughout the consultative workshops, as well as talking with donors who fund commodities in the family planning supply chain, it became clear that not all donors have policies in place to ensure that the recipient location has equipment and consumables, nor do they always include these materials in requests for proposals. Second is the global family planning community. Equipment and consumable supplies are often not fully integrated into global tools, procurement processes, and formulas. Further, these solutions that might exist are not always made well known. For example, tools like the Costed Implementation Plan costing tool does not include specification of the consumables and supplies required for service provision. Similarly, while procurement of contraceptive commodities, like IUDs or implants, are tracked through a centralized mechanism, like UNFPA, this data does not always include procurement details for the associated consumables and supplies. And third, a standardized equipment and consumable list does exist for all LARC methods, though it may not be widely utilized or available. Third are governments. There is great variance in how governments manage understanding of what's needed, the associated costs, national standards, and who holds the ultimate responsibility for these materials. For example, we analyzed several costed implementation plans and found them inconsistent in their inclusion of equipment and consumables for planning and costing, ranging from no mention of equipment and consumables to full costing analysis of these materials. This variability not only means that sometimes these materials aren't included at all, but there's also a lack of guidance on what extent they should be included in the costed implementation plans, as well as the subsequent strategy plans. Second, there's no standardized forecasting formula or guidance that exists for consumables and equipment, which makes it difficult for governments to manage how many materials they should plan to budget when they implement costed implementation plans. The fourth driver that we looked at are subnational governments. At the subnational level, there is often limited knowledge and skills to manage procurement of these items, particularly in devolved settings, coupled with an unclear understanding of the role that subnational governments play. For example, in the country consultation workshops, several stakeholders revealed that the mechanisms for procuring equipment and consumables in devolved health settings had not yet been explored or systematized in the context that they were working in. And the final driver for insecurity that we looked at were health facilities themselves. At the health facility level, these materials cannot or are not isolated to a single service area, meaning that isolated efforts to address this issue won't resolve insecurity. In several contexts, determining order quantities and procurement were noted as the primary facility level challenge in the reliable availability of equipment and consumables for family planning. We currently have little understanding of how these materials are managed once within the facility. For example, sharing items across units, tracking the consumption of consumables, and the regular processing and replacement of reusable equipment. In addition to the supply chain considerations that are driving this issue, there are also different environmental shifts that can cause the issue of equipment and consumable supply availability to be more exaggerated. First, increased risk for insecurity is introduced when a new family planning method is introduced, especially if that method requires increased equipment or consumables. For example, if a country were to introduce implants into the method mix when they previously did not have them. Second, increased risk is introduced when a period of method mix shift is occurring. So if shift is occurring perhaps away from birth control pills towards IUDs in a country, this could also create supply chain insecurity, since these methods are often more material intensive and an increase in number of users will necessitate an increase in the materials. Third, increased risk is introduced when services are newly task shifted or task shared. This is due to the increased number of providers who are using the materials. Fourth, increased risk can be introduced when the supply chain management is devolved or decentralized, often stemming from a lack of clarity over roles and responsibilities. And fifth, similarly to the one above, increased risk is introduced when health facilities or subnational health offices are given increased financial autonomy. This is largely due to lack of clarity of roles that can come with increased financial autonomy. These environmental shifts can not only help to plan for emerging concerns about equipment and consumable supply availability, but can also help to diagnose some of the existing challenges within the supply chain. So with those findings, we move into our opportunities for action. In this final section, we want to share our primary recommendations and advocacy approaches. These recommendations were shaped through consultative processes, including significant feedback from in-country stakeholders in the Uganda, Nepal, and Ghana sessions. This list is certainly not exhaustive, and the white paper explores several other recommendations for addressing equipment and consumable insecurity. While addressing equipment and consumable insecurity will require collective action and innovative approaches, engaging cross-sectoral stakeholders and global leaders, there are several tangible and immediate steps that will begin this process. These challenges may feel daunting, or at the very least complex, but we are hopeful that these recommendations will not only create a collective sense of urgency, but also concrete ideas for moving forward. Our first recommendation is that we need evidence that captures impact. To fully document, quantify, and understand the extent to which equipment and consumable insecurity impacts the delivery of family planning services and thereby hinders family planning goals, significantly more research is required. The white paper began the process of assembling existing data, but more research is necessary to fully grasp this issue. Second, we need a better understanding of the facility level challenges. Additional investigation is needed to explore the ways in which facility level procurement and stock management occurs, as well as what ideal solutions might look like. Specifically, we need to explore consumables and equipment as integrated materials, often used in order to cross services. There is great variety in how individual facilities manage the procurement of these materials, and a better understanding of facility level challenges will shed light on potential solutions. Third, better methods to quantify equipment and consumable needs should be developed. This is the first step towards getting the practical data that is needed to enhance visibility of this problem and can help resolve some of the data-driven challenges. This will also help guide future procurement and planning in country settings, as well as scale up of methods that require more materials. Fourth, roles, funding lines, and accountability on equipment and consumables need to be made explicit. The question of who is responsible for paying for consumables and equipment has no simple answer. Throughout this process, and even in this call, we were unable to find a clear answer and consensus regarding those roles and responsibilities. Clarity on roles and responsibilities will help create needed accountability mechanisms for addressing this insecurity. And fifth, additional resources and attention are needed. To bring more perspectives and solutions to light, additional resources will be required. This will also require engaging supply chain and costing experts, as well as people who can carry forward the advocacy messages and actionable outcomes. And then on this slide, this just shows us a summary of those recommendations. So really focusing on the need for better evidence, better understanding of what's happening within individual facilities, developing quantification methods, clarifying roles and responsibilities, and setting aside additional resources and attention to explore this issue. Finally, to close, we wanted to provide a series of advocacy recommendations. While each of the recommendations that we presented above will require a tailored approach, depending on stakeholders and country contexts, all approaches will require advocacy. In this final section, we explore an advocacy prioritization checklist to direct those objectives. In considering how to move forward with these recommendations, each intervention will require tailoring to the specific country context. We recognize that supply chains and procurement mechanisms differ from country to country and even facility to facility in many contexts. However, the following prioritization tools will help you direct your next steps. First, we recommend starting by mapping out the supply chain for equipment and consumables. In this process, consider all of the different processes and stakeholders that are required to get a consumable. For example, use medical gloves, from the point of production to the hand of the provider. Ideally, in this setting, you would convene stakeholders across the supply chain, so people from the government level down to the implementation and provider level, to see where some of the different processes and overlaps exist. In the second step, identify duplicative processes or gaps. Identify the ways in which the processes might be made more efficient or potential gaps that exist within the supply chain. Again, we would recommend including a variety of stakeholders who can shed light on different sections of the supply chain and different processes that are happening in country. Third, identify the risks. Recall the environmental shift scenarios that we presented earlier and determine if any or multiple of those scenarios are happening within the individual context that you are working in. If they are, this can help shape your planning. For example, if you're working in a setting that has a devolved supply chain setting or a devolved health institution, then you know that this might be at higher risk of equipment and consumable gaps, and you can integrate that into your planning. And fourth and finally, identify the advocacy sequence and potential quick wins. Consider quick wins that are most relevant to the objectives for a specific country context, and then determine the order that those wins need to happen in order to move collective action forward. Finally, if you want to learn more about the findings or explore the recommendations further, be sure to check out the white paper, which is now posted on the RHSC website at the URL above. We'll also make sure that we circulate that information following the webinar. With that, I will turn it back over to Megan to close us out.
Sure. Yeah, just to say thank you, everyone, for listening to our rationale and our methods, as well as our findings and opportunities. At this point, we would love to answer any questions that you have or hear some perspectives on this that you might have chatted in to the chat box. If you're holding on to it, please chat it in now. And if we don't get to your question, please feel free to follow up by email to me or to Sarah. Our emails were on an earlier slide, but you can also send those questions to Greg from RHSC on email, who will also funnel them to us. But at this point, Greg, do you want to open up some of the Q&A and let us know what's coming through?
Absolutely. So let me just read off the first question for you right now. This is from Jason Bremner. Most of the consumables are not specific to family planning service delivery. So should family planning donors or family planning vertical programs be responsible for the funding of these items? That's the first question. Second is, I think it's important to quantify the percentage of total use of consumable supplies that LARC delivery represents. I would guess that the growth in delivery of LARCs would only result in marginal increases in consumable supplies in comparison to the total use of these by the service delivery point. For example, gloves and forceps are going to be used far more often than other services deliver. So do you need me to repeat the question in the beginning, or do you got it?
Sure. Yeah, thanks, Jason. These are great questions. I think this is Megan. I think that point on the integrated nature of these materials, which it was a common thread through both your questions, is a really accurate sum on your part, because I think this is where we found it was really challenging to try and isolate our problem exploration or our kind of this opportunity exploration for family planning alone. And yet that's how we entered into this. And so I think time and time again, we were hearing, yes, but these materials, even if you procure the number of gloves or the number of forceps needed for family planning, those materials are still going to be used by other services. And so you're never going to be able to fill it by looking at family planning alone. I think this goes into Sarah's points about where some of the next steps really lie in exactly what you're saying about figuring out who is responsible when it's not for a single service area, and what are those quantities, what are the volumes needed for family planning vis-a-vis other services. And unfortunately, that wasn't something that we could cover in the scope of this paper, but I think as you saw, would highly, highly recommend as one of those top 5 recommendations for the next steps.
Great. So thanks from Jason. Next question we have is from Elizabeth Nosneski. Thank you so much for your presentation. Many of the items used to provide LARC services are used for many other services, for example, gloves, etc. So quantification will need to consider all services, not just family planning. Is there an opportunity to work with primary health HHS stakeholders to increase supply of LARC consumables and equipment?
Yeah, thank you. I think that's a great question. And as Megan kind of spoke to in the previous answer, we definitely ran into a lot of instances where stakeholders or providers were saying, you know, these materials are not isolated to the family planning setting, and are used across multiple settings. I think there's sort of 2 different recommendations that we would have for that. So the first one is that one of the challenges we were running into was that for some of the equipment and consumables, it was very difficult to quantify what was needed to scale up LARC methods. So for things that have a one-time use, it's a little bit easier to say, you know, you need 1 unit of this to do 1 implant insertion. But for things that can be reused after a cleaning or sterilization process, we thought it would be helpful to have some sort of quantification formula that could help predict sort of how many speculum would you need to order, for example, based on the volume of IUDs that you were planning on implementing, or, you know, kind of similar things to that. And I think that would help address both the quantification and sort of thinking through costing of those materials, but would also help with some of the sharing of those equipment that are used across multiple different units within a health facility, because there would be a better sense of how much of it was actually needed for family planning as opposed to some of the other services that are being offered. And then second, I think it is a great idea to engage primary healthcare stakeholders, especially if the way that materials are being ordered within that specific health facility pools across the different units within the health facility. But I think that's a great idea to further explore.
Yeah, and I think you might hear us kind of saying yes to both, that there is a need to isolate the quantification needed for family planning, and also consider what is the total need for some of these materials that are used in multiple services. Because, you know, our finding were that, yes, they are used in every service, but even in family planning, we don't have a clear formula or understanding of those volume needs. And so maybe one of the assumptions that we carry is that starting to answer the question of what's needed for family planning could help to answer the larger questions about what is needed for primary health care. Though I think it's a good point that we should be engaging with that community in order to really understand if that hypothesis is true. So we'll take that one, and we've noted it.
Great, we've got a few more questions here in the queue. The next one is from Mark Hathaway. Can you talk about a facility that had all of the supplies needed and what you think was the difference between them and a facility that didn't have the supplies needed?
Very good question, Mark. So yeah, I think from the consultations, I think the closest we can approximate to why and where and why this is happening is when there is a, let me say, like a heavily funded partner agency who is delivering services directly at that facility or providing pretty intensive support, is where some stakeholders felt like they were seeing better security or better availability of those materials. But it was still widely variable. And I think also there were some comments we heard from in the consultations that it also isn't only about the facility, but even for areas within a facility. So for example, stakeholders largely felt in some countries that services like HIV related services were much better stocked with equipment and consumables for the necessary services they provide than family planning or even maternal health. And so it might not even be about a single facility that's really well stocked as much as looking within that facility to see where is it going well and what are the conditions that made it so. And again, I think this actually goes back to one of our recommendations that kind of understanding of what's happening within facilities was really not something we understand very well, and where we recommend some additional, probably primary data collection, which was one of the limitations of this project. Yeah, thanks, Mark.
Great. Next question we have is from Jhpiego. Thank you for this insightful presentation. Do we know the extent of these challenges in the private sector?
That's a great question, Jhpiego. No, I don't think we do know the extent of these challenges in the private sector. I'll say in one country where we did our consultation, where they have a pretty really robust private sector, I think the stakeholders, who I will admit were much more public sector focused, still kind of went back to this idea of these materials all cost money. And for private sector stakeholders, we have to think about whether or not they can make the capital investment in some of these materials, or what we can do to subsidize capital investment in order to make that easier. So for example, you know, a private facility, and again, this was sort of an assumption that was shared at a country consultation, so we can't necessarily validate this, but the perspective that was shared by a ministry person was that a private facility might actually shy away from providing something like LARCs or permanent methods at all because of the capital costs required to procure, you know, the autoclaves, the equipment, et cetera, that are kind of that's an initial barrier. And so I do think it would be helpful for us to look more closely at private sector going forward, which we probably didn't do very extensively.
Yeah, and I think kind of to add on to that, really the only data that we were able to glean about that was the performance monitoring for action data does delineate in their findings between public and private facilities. So we could look at, you know, were private facilities, for example, more likely to have the materials in stock. And based on the data that's been published, there were a handful of countries where private facilities had a slightly higher percentage of facilities with materials in stock. But for the most part, we were actually seeing relatively similar percentages across both public and private facilities of facing this issue of not having the equipment and consumables necessary. But yeah, great question. Thank you.
Great. We have another one from Mark here. Apologies for the delay here. There's a lot of questions coming in, and I'm scrolling and missing. Here we go. You may have talked about this, but not one of them. But if not, one item often discussed is the equipment needed to sterilize instruments. Did you find this?
Yeah, so that's a great question. So we did talk about this in the scope of the white paper and kind of decided to focus more on the materials that were needed at immediate time of service. So for example, we didn't include autoclaves in the investigation. And I think that further investigation into that issue of equipment sterilization and kind of what that process looks like would be incredibly helpful. But for the sake of sort of isolating the family planning unit and looking at those impacts within family planning specifically, navigating that kind of upstream supply chain was a little bit more difficult just in the confines of this research or this project. And so I think future projects or data collection could look into that a little bit more. But I'd be interested to see what those findings were.
Great. We have another follow-up question from Kuyosh. Also, what are the costs associated? How much does a facility owner need to invest to ensure supply of consumables equipment? Thank you.
Mm-hmm. Yeah, Kuyosh, I mean, that's a question we have as well. Yeah, I think we don't know the answer to that. And some of those answers rest in our ability to even understand the quantities required in the first place. As Sarah noted, you know, sometimes it's easy to make that calculation if you assume, you know, one procedure equals one set of gloves or two set of gloves if there's two professionals, right? But that gets a little more complicated when we're thinking about equipment of a reusable nature, and we don't know the lifetime usage for a single surface, much less the entire facility. So I think we're on the same page as you that is absolutely a question that needs to be answered going forward.
Great. Another question here is from Rajendra Bhadra. Is data generated from health institution service readiness or SBMR helpful in estimating need of such equipment or supplies?
Yeah, that's a great question, Rajendra. I mean, I think there are so many places where data on equipment and consumable actually exists. And those places have a lot to do with facility assessments that are often conducted by so many different institutions, whether it's an implementing partner before they do an intervention, or it's a subnational health office who's doing supportive supervision visits. I think the reality is that we actually are looking at consumables and equipment all the time. We're looking at it to determine facility readiness. We're looking at it, in isolation in single initiatives. And yet, of course, there's no single place where all that data comes together. And so I think it's a great point that we can look more closely at facility and readiness assessments done by individual institutions or for isolated programs, and try and glean a little bit more out of those. And certainly we shared a little bit of data from some of Jhpiego's facility assessments under a single project earlier in this presentation, but certainly we recognize that others are doing similar activities all the time. So yeah, maybe there's actually a recommendation there about standardizing what exists in those readiness assessments or something. We'd love to hear your thoughts on that, Rajendra.
Great. Next question in the line is from Nastasia Campbell-Lamy. As an NGO, what could we do to attract more persons to take these family planning methods as they are scared and tend to shy away from them because of hearsay?
Sorry, Greg, was that about providers or clients? I missed that.
Can you repeat the question? As an NGO, what could we do to attract more persons to take these family planning methods as they are scared and tend to shy away because of hearsay? We're talking about clients.
Oh, okay, yeah, great question. I mean, I think obviously I think there's a lot of research and best practice out there about social and behavior change and about messaging around family planning and the role of healthcare providers and communities in sharing accurate information. Yeah, so maybe we can follow up offline about some additional resources on that.
Great. We have another question from Jason Bremner here. UNFPA supplies facility survey in many countries each year. It includes data on stockouts and may include data on consumables and supplies, a report on sterilization, supply stockouts in the FP 2020 report. So more of a comment than a question. Going on down the line, Maricela Fleming wrote again, are other equipment like lamps, consultation beds, or ecograms included in the possibilities? And then she also asked, testing materials for STIs are included in the consumables as well?
Yeah, no, yeah, it's a great point. So we really did isolate this into the materials that are needed directly at the point of service or the time of service for family planning. But you're right that there are so many other pieces that are actually required, whether it is equipment like beds, lights, running water, autoclaves, as Sarah mentioned, et cetera. And at the same time, you're right that STI testing services, et cetera, also require those materials. I mean, I think, yeah, we recognize that. And I think, obviously, we can't assume that our findings specific to family planning are felt on all other service areas, but we would encourage this exploration and even the process that Sarah outlined for mapping supply chain for equipment and consumables. You could apply that to any service area, right? You could say, how do the gloves for our STI testing kits, or how do the lancets used for STI test or for blood testing, right? Like, how do those make it to the point of service delivery, and try and uncover whether or not there are any gaps or duplication in the supply chain.
Great. So I think we're running out of questions. There's a lot of great comments and some resources that have been shared as well. Here's one question. Do you think the Caribbean will experience the same challenges in family planning procurement?
Do we think what will experience?
The Caribbean will experience the same challenges in family planning procurement? So is this?
I don't know. That's your guess is as good as ours. You know, Sarah mentioned that the countries that we selected for the consultations were chosen for diversity in a number of ways. And so just to note that, we had Nepal, Ghana, and Uganda. And it was both because of their geographic diversity in terms of, at least one country from Asia, one from East Africa, one from West Africa, but it actually also had a lot to do with looking at, what is their method mix? So for example, Nepal was selected because they have predominantly a permanent and long-acting dominant method mix. And we felt like that shows us something about an ability to deliver on some of the equipment and consumables required to really achieve that method mix. Versus another country which might have a different mix with shorter acting methods, taking more of a proportion. And so, just trying to understand how does this exploration change based on a number of factors. We also looked at the diversity of supply chain management. So Ghana, for example, is well known for having a very robust supply chain planning committee, and with very kind of robust supply planning capabilities, their cost implementation plan, captured equipment and consumables within it. And so again, looking at some of those factors. And so for the Caribbean, I think we'd have to understand a little bit more about what are some of those elements, like what are the method mix, what are the existing practices, what is being documented currently in supply plans, to be able to see whether or not the challenges and opportunities might be felt the same.
And I think to kind of go off of that as well, sort of thinking again about those environmental shift scenarios. So if there's a particular country that's seeing like a drastic increase in the number of LARC users, or the introduction of a new method, for example, I think those different scenarios that are now up on the screen again could also shed light onto that. So if there's a devolved supply chain management system in place or increased financial autonomy happening kind of at the subnational level, I think these environmental shifts really did shed light on a lot of the obstacles that we saw in having equipment and consumable security. So I would suggest also just looking at the particular country context and whether any of these environmental shifts are happening there as well.
Great. So we have a number of comments, although I think it's difficult without opening the mics up for everyone to discuss. This kind of a difficult forum it seems as though there's a discussion happening in the question section. People are responding to questions with their own comments. I don't think we have enough time to read through all of them, but there's some really great ones. And just for everyone to know, we have a log of all the questions and comments. We'll share them with Jhpiego and the presenters. And in the shortest time, we have about 2 minutes left. So unless anyone has any other questions, I think we can just continue to log these wonderful comments and share them afterwards. And to the presenters, a lot of the comments also are just saying, great job on the presentation. Thank you very much. This is a great topic and really eye-opening, so on and so forth. So I just want to express my gratitude to you as well. So with that, I just want to say thank you to our presenters, and thank you to all of our participants who joined in on the webinar. I think this is a really great conversation and discussion following a wonderful presentation. So I don't know if either of you have any closing comments you'd like to make before we conclude for today.
No, yeah, we would also just echo your gratitude to all of the participants for joining. We really appreciated the active and thoughtful engagement and participation throughout. And then a big thank you to RHSC as well for making this white paper possible. So thank you to both Greg and Anjali for facilitating today as well.
Great. Well, with that, thank you, everyone. Enjoy the rest of your days, and hopefully we'll catch you in the next webinar. Have a nice day.